Hello students, welcome to this session. Today's topic is physiology of menstruation. Let's move on to the learning objective. Let's learn about the follicular stimulating hormone, luteinizing hormone and anti-Mullerian hormone functions and role in menstruation. Hormones. What are these hormones? Hormones are the chemical substance synthesized in a small amount in the endocrine tissues and carried by these bloodstreams to the other tissue and acts as a messenger to regulate the function of the target tissues or organs. So let's see the classification of hormones. Classification of hormones divided into amino acid derivatives, polypeptide and glycoprotein, steroids and fatty acid derivatives. So the example for the amino acid derivatives is catecholamines. The chemical composition of this is C, H, N and amine group. The polypeptides, insulin and glucagon, glycoproteins, LH, FSH, steroids, corticosteroids and sex hormones. Fatty acid derivatives, prostaglandins, leukotrienes and thromboxanes. So what is this luteinizing hormone and its structure and classification? It's a heterodimeric glycoprotein. Each monomeric unit is a glycoprotein molecule, one alpha and one beta subunit. Alpha subunit is similar in all glycoproteins and beta subunit consists of 120 amino acid that confer its specific biological action and is responsible for specificity of this interaction with LH receptor. The carbohydrate part consists of different oligosaccharides. The biological half-life of LH is 20 minutes. During reproductive years, this typical level of LH are between 1 to 20 international units per liter. In males over 18 years of age, the reference range has been estimated to be 1.8 to 8.6 international units per liter. So what's the origin and production of this luteinizing hormone? It's produced in the pituitary gland under the regulation of a gonadotrophin hormone releasing hormone. It's then released into this bloodstream towards the target tissue. If you see this diagram, this hypothalamus secretes gonadotrophin releasing hormone, acts on the anterior pituitary. From there it secretes a LH and which acts on this target organs, includes ovaries and other parts of the body. Target tissues and function. LH supports the cortical cells in the ovary which provide androgen and hormonal precursors for estradiol production. LH surge triggers the ovulation, releasing of egg from the follicle, initiating the conversion of the residual follicle into corpus luteum. It also produces progesterone to prepare the endometrium for implantation. What's its role in male? LH acts upon the lytic cells of the testis and production of the testosterone and androgen. Exert both endocrine activity and intratesticular activity on the spermatogenesis. Next, we will move on to the follicular stimulating hormone. It belongs to a glycoprotein. The chemical composition is two monomeric subunits of proteins and carbohydrate. It has an alpha subunit with 92 amino acids and beta subunit with 118 amino acids. It also has 4 carbohydrate side chains, 2 for each subunits. Beta subunits is more specific and biological activity and interaction with the FSH receptors depends on this beta subunits. What is its origin and production? It's again controlled by GnRH, released into the hypophyseal portal, circulation to acts on G protein coupled receptors at gonadotrophin cells of the anterior pituitary. It has low amplitude, high frequency pulse which stimulates this FSH. Alpha subunit is identical for all the glycoprotein hormones TSH, beta HCG, LH and FSH. But this beta subunit differs. FSH production also influenced by inhibin, activin and follistatin. Suppressed by estrogen and inhibin, enhanced by actin. The peak of the FSH is coincident with the peak of LH and it is lesser in the magnitude and briefer duration. Functions: recruitment of the follicle, estrogen production, follicular growth, acts on the granulosa cells in the ovarian follicle. It increases the number, increase in LH receptors, increase in aromatase activity, converts androgen produced by the T cells into estradiol. What's its role in male? With testosterone is necessary for maintaining the normal sperm count and function. Also, studies have shown FSH deprivation not only lower the sperm count but also affect the quality of remaining sperms. FSH receptor, half-life and normal values. FSH receptor is a transmembrane receptor in granulosa cells of the ovary and Sertoli cells of the testis. Predominant effector pathway via activation of adenyl cyclase through a G protein. The plasma half-life is 3 to 4 hours. During the follicular phase, the values are between 2.8 to 11.3 milli-international unit per ml, whereas in luteal phase it's 1.2 to 9, in mid-cycle 5.8 to 21, and in a post-menopausal age group it varies between 21.7 to 153 milli-international units per ml. A role in normal menstrual cycle. It has two peak levels in the menstrual cycle. One is during the follicular phase and the 6th day of the cycle. FSH rise in the later half of the luteal phase with the loss of the function of corpus luteum. After recruited follicle, one with the maximum number of FSH receptors, that is dominant follicle. Developing follicle produce increased amount of inhibin B and estrogen. It leads to the inhibit the FSH production by gonadotrophin, thereby FSH levels start falling after the peak on the 6th day of the cycle. Leads to the dominant follicle continue to grow, all other follicles become atretic. So, the second rise is during the pre-ovulatory phase on the 12th day of the cycle. In response to this increased GnRH output by the hypothalamus, concurrent pre-ovulatory LH surge happens. That will lead to, then the levels will decrease and remain slow till the late luteal phase. Suppression by the progesterone, estrogen and inhibin A. By day 22, the corpus luteum failing in function leads to FSH rise again. This initiates the next cycle. In hypogonadotrophic hypogonadism, in case of amenorrhea with the low levels of FSH and LH, due to defect in the hypothalamus or a pituitary gland, it can be due to stress, it can be due to Kallmann syndrome. In stress, what happens? The stress induced hypogonadotrophic hypogonadism. When the calorie intake falls, short of energy expenditure, the physiological stress decreases the hypothalamic GnRH pulse, frequency and amplitude, leading to low FSH and LH level. Thus, the anovulation and amenorrhea occurs in female athletes and individuals with eating disorders due to lack of adequate calorie intake and excessive exercise. What happens in Kallmann? During the fetal development, GnRH producing neurons of the hypothalamus develop from the epithelium of the medial olfactory pit and then migrate. In this defect, in migration, anosmia and hypogonadotrophic gonadism results. The next group is polycystic ovarian disease, where there is a elevated androgens, polycystic ovaries and anovulation. Patients with PCOS often present with hirsutism, obesity, insulin resistance and menstrual irregularity and infertility. This persistently rapid GnRH pulse will lead to elevation in the LH and FSH ratio. The cortical cells produce excess androgen, but the granulosa cells don't produce enough aromatase to convert the androgen into estriol. The test for ovarian function. The day 3 FSH serves as a test for ovarian function. Less than 10 international units per liter is normal. Elevated levels more than 12 international units per liter or especially more than 20 international units per liter associated with poor performance with in vitro fertilization. When the levels are more than or equivalent of 25 international units per liter, more than 44 years independently associated with chance of pregnancy close to zero during ovulation induction or with ART techniques. It varies with lab significantly due to difference in antibodies and standard used to measure them. Premature ovarian insufficiency. In case of amenorrhea with the elevated levels of FSH, ovarian premature failure occurs. Ovarian failure and menopause occurs before the age of 40, leading to elevated FSH level due to lack of negative feedback from ovary, multiple genetic causes. Most cases are idiopathic. In Turner syndrome, most common genetic disorder causing premature ovarian failure due to karyotype XO or a primary amenorrhea when underdeveloped ovaries or a steak ovaries with elevated FSH levels. FSH levels and male infertility. In male with a small firm testis, azoospermia or oligospermia, there is an increased FSH level. Differentiates Klinefelter from hypothalamic or pituitary insufficiency. If testis is normal with azoospermia or oligospermia, FSH determines the cause. Obstructive causes of infertility with a normal FSH level. Elevated FSH with a primary impairment of spermatogenesis. We'll move on to anti-Mullerian hormone. Alfred Jost, a French endocrinologist, who first time named this dimeric glycoprotein hormone, belong to TGF-beta family. AMH gene mapped into the chromosome 19, produced by granulosa cells of preantral and small antral follicles in females. It's produced by Sertoli cells soon after the testicular differentiation and is responsible for ipsilateral regression of this Mullerian duct by 8 weeks. Despite its presence in serum up to the puberty, lack of regression of the uterus and tubes is the only consistent expression of a AMH gene mutation. What's its action? It inhibits initial follicular recruitment. It also inhibits FSH dependent growth and selection of the preantral and small antral follicle. Begins during the primary stage, peaks in the preantral and small antral stage, then decreases to undetectable levels as follicles grow larger. AMH levels are low in females till puberty, decline slowly over the reproductive lifespan as size of a pool of remaining microscopic follicles decreases. Frequently, below detection limit of current assay after the natural or a premature menopause. In the ovary, very small amount of AMH and mRNA are present early in life, and although there may be no role in female development, its production later in life by granulosa cells raises the possibility of autocrine and paracrine actions in oocyte maturation and follicular development. What's its normal range? The range is high in PCOS where preantral follicle levels are high. So, the values more than 3 nanogram per ml is common in PCOS. The normal range is more than 1 nanogram per ml. The low normal 0.7 to 0.9 and the low is 0.3 to 0.6 and very low when the levels are less than 0.3. So, the male fetal development inhibits the formation of the Mullerian ducts, is secreted at the time of Sertoli cell differentiation, which at the beginning of the 7 weeks. AMH expression is altered only by mutation in the AMH gene. Regression of the Mullerian ductus depends on the presence of adequate number of Sertoli cells and probably the regulation of the AMH receptor. After involution of the Mullerian system, AMH continues to secrete, but there is no known function. However, evidence in the mouse suggests the role of early germ cell transformation during this process of spermatogenesis. Elevated levels in males less than 2 years, then decreased until puberty, then there is a sharp decline in male. It's used as an ideal marker of ovarian reserve, indicative of a size of the growing follicle pool. The serum levels declines with age, therefore, the marker of a ovarian aging. Changing in serum AMH occurs relatively early in the ovarian aging as compared to the late changes in FSH, inhibin B and estrogen. A good predictor of both excessive more than 3.5 nanogram per ml and poor, the value less than 1 nanogram per ml. In IVF stimulation response and strongly correlates to the antral follicle count. Thus, a marker of ovarian response in treatment of infertility helps predict outcome of the in vitro fertilization. Why best indicator for ovarian reserve? The specificity for Sertoli and granulosa cells. Due to a gender differences in serum level, it's a good indicator of a change in sexual development. It's also produced continuously as compared to pulsatile production of gonadotropin and ovarian steroids. Serum levels are unaffected by pregnancy, oral or vaginal contraceptives. Can be measured at any time of the cycle. That's one of the biggest reason why it's an ideal indicator of a ovarian reserve. What's its other clinical application? It's less used condition in case of ovarian functions in PCOS, menopausal status, evaluation of the infant with ambiguous genitalia and other intersex conditions, testicular function in infants and children, diagnosing and monitoring the AMH hormone secreting ovarian granulosa cell tumors. Students, these are the reference for this presentation. With this, we end our session. Hope you understood. Thank you.